Hello, and we are doing chapter 5, supportive and psychodynamic therapy. And this type of therapy works really well in medication management appointments, really offering that psychodynamic relationship within the patient and offering that supportive nature that they need. So, definitely something to think about when offering therapeutic techniques within appointments. So let's talk about the history. We have Sigmund Freud, who is the father of the psychodynamic therapy. Then we have interpersonal therapy, and then object relations with Mailer, and then ego psychologist Eric Erikson, self psychology, and the relational model. So kind of all going into that psychodynamic therapy, and Wheeler really goes into that and talks about that. And I think it's important to know the history of the therapy and how you can utilize this within your relationship with your patients. So Freud developed the psychosexual stages of development. And I think we've all learned Freud even in our BSN, the oral stage, 0 to 1, the anal stage, phallic stage, and then the Electra complex, things like that. How is an adult fixation an example of these, of latency and genital? So looking at oral, it would be like smoking or overeating. Anal, so you've probably heard the phrase with somebody who's super orderly, oh, they're so anal. And that's where it comes from, Freud's psychosexual stages of development. And so phallic, deviancy, sexual dysfunction. Are they stuck in these stages? That's kind of where Freud was going with that. They're kind of stuck in the oral stage for some reason. So just something to think about when people bring up stuff. I don't utilize really any of the psychosexual stages of development within my appointments. I leave that up to therapists. But it is interesting when someone brings up like an OCD behavior, Freud will pop into my mind. Oh, they're stuck in the anal stage. Maybe something happened in toilet training. But I don't bring that up because I don't have time to evaluate that. And who knows if even the patient, understands what happened at that age either. So the basic tenets of that is drives or instincts are the motivations for behaviors. And psychic determinism, it's all unconscious, and the role of the childhood experience in shaping the personality. So childhood, Freud is right. Every so often I'll get somebody in my office and I'll be like, oh, Freud was right on that one. Things that happen, and really knowing out of all of this that Freud did the psychosexual stages of development, that they're really unconscious, and that they're things to just pay attention to because psychodynamic therapists agree that understanding the unconscious structures and patterns in daily life and really understanding that is an ingredient to understanding the person. So it's all like these hidden concepts that are going on. And looking at this, the structural model with what Freud kind of talked to, and I do believe he had something going on with the superego, ego, and id. So I think what you really need to take home from this is like the id is part of the unconscious mind. It's our primary processes. It's just all unconscious. It's just part of who we are. And then, taking home the ego is what the person is aware of when they think about themselves. So being aware of that in terms of the superego is what we're more conscious about then, our morals, our values. And what shapes them is the id and the ego, shaping that superego and just being fully aware of that. So I think just knowing that, Freud did the psychosexual stages of development, that id and that ego and that superego, and being aware of that. And things are posted in Blackboard for you to fully understand it. And it's really worth taking a look at, because you will get patients that you see that Freud really connects with these thought processes. So our subconscious has body memories, and memory is just not cognitive and what we remember in words, but also implicit and procedural memories that are stored in the body. So sometimes, what you see in our conscious are really, there's a lot of subconscious and unconscious stuff going on in there. And that's where kind of therapy comes in, is to really understand kind of those memories and past experiences that are going on. Maller's stages of separation for an individual. You can pause and go over that, and I know Wheeler goes over that somewhat. Looking at that is important in terms of, if somebody has an attachment disorder, like a reactive attachment disorder, and where did they struggle, and if they had trauma, and really kind of understanding kind of those ways of separation that maybe the child wasn't supported during that time. I like Erickson's psychological stages. I see this quite a bit, and as we go through his stages, I see this really a lot when people get to, their adult years and where they're progressing. And I think really take a look at this and understand it, because it does show where somebody may be struggling, and really bringing this up, you're stuck in this other stage. So infancy, trust versus mistrust. We have autonomy versus self-doubt. And you'll see this in kids, if you see younger kids, initiative versus guilt. These kids that are really guilty, are they assertive or are they aggressive? Do they have phobias? Psychosomatic, initiative versus guilt. I see this in little kids. In industry versus inferiority. And I see a lot of this in kids too that have a lot of bullying. They're really stuck in that inferiority. And these other kids really are doing well and thriving, and they're doing industry. They're moving forward. They're creative. They're competent. And then you have these other kids that are stuck. Part of that could be, guilt too, stuck in guilt, but also that bullying and not feeling good enough. And then moving forward, we have the adolescence, identity versus role confusion. And I think, I see a lot of trans teenagers, and I think there's a little bit of role confusion that goes in there, and really understanding who they are and just supporting them to help them find their identity. And I think it creates role confusion because they're confused on it. I feel like a boy, but they were born a female. And there can be a lot of role confusion within that. So pathological outcomes, especially with role confusion, delinquency, if they're running with the wrong crowd, they don't know what their identity is, and gender-related identity disorders, borderline psychotic episodes. I do see this a lot in adolescence. These stages I've seen on the board questions, and I know on my FMP boards I had the stages of development. So definitely highly recommend that you review these stages, that you really take them to heart and understand them, because you will see this in practice too. And then we have the young adult, up to 30, intimacy versus isolation. And you'll see this a lot. These I still consider them young, and I guess it's called young adult. They're young, before the age of 30. And so they're really isolated. They're not feeling they can get a relationship. They're staying at home. They're living in their parents' basement. And I do have one that fits this to a T with schizoid personality. Fits it to a T. Every time I see him, I'm like, my gosh, you are stuck in isolation. And then the more I've learned about him, I sent him to therapy because I just felt like he needed more support. And the therapist was able to get more out of him. And there was struggle with intimacy with previous relationships, people cheating. And then I found out all sorts of things about him that I didn't know because I don't have the time to find that out. Oh, bear with me. My husband is vacuuming, so you probably hear a vacuum. So super important with that, really understanding where this person is in their Erickson psychological stages. And then adulthood is basically adulthood and old age. Really understanding, are they feeling like they're making a difference in adulthood, or are they stagnant? So midlife crises occur during this time because it goes up to the age of 65. Are they feeling like they're successful in their role at work? They're just feeling stagnant, stuck in a position that they may not be happy with, and they're feeling very stagnant on it. And you can bring that up. There's no medicine to get you through the stages, the psychological stages. So being aware of these stages and being cognizant of them, and also saying there's not a medication that can change that. You're stuck in this stage and we need to move you forward. And what I really see, especially when people retire, and if they retire early in adulthood up to the age of 65, I see that stagnation because they don't have a purpose, they don't know their purpose, they don't feel their purpose, they get depressed, they get overwhelmed. So some people do really well when they retire, and some people go stagnant. So I think that's important to understand too when evaluating people when they come to your office. And then old age, 65 and older, ego integrity versus despair, you will see this. And Erickson hit it on the head. I see it all the time, and I talk to patients, and there's no medication, that's going to fix this. This is working through that stage and really understanding where you are in that stage. Extreme alienation, they're not part of their family, they have no support system, they have a high level of despair, and really helping them develop who they are at that old age and what life means to them. And really, a lot of regrets that you'll see in this age group. I shoulda, coulda, woulda, yeah, but, and ifs, I call it. All of those that people have in that ego, despair that they're having. So definitely knowing those stages. Recommend that you know these stages. They will pop up on your boards, maybe final exam. So definitely be aware of them. So with this type of therapy, it's psychodynamic, supportive, exploratory, expressive, psychoanalytic orientated. So very Freud orientated, very supportive. Let's explore that. Tell me more about that. How does that make you feel? Kind of statements within that. Not so much trying to switch thought processes on things, but really just being supportive and exploring. Looking a little bit closer at this, looking at it is just a way to kind of view how psychodynamic therapy can look in terms of how you can help the patient and what diagnoses and stages they may be stuck in. So it's just interesting. I find it very interesting. We have the psychodynamic continuum, counseling, supportive, expressive, and psychoanalytic. You want to restore function, reduce that anxiety, strengthen their defenses, and facilitate problem solving. And through that, you will help with interpretation of unconscious conflict and help them gain insight. So it's really kind of tapping into that id and that ego and really understanding what's going on with that patient to help them move forward with where they're stuck. As we talked about in previous lectures. Processing leads to expansion of consciousness. They will have some destabilization as they're processing, so definitely be aware of that. Bringing up that resilient zone again. I think you're going to hear this throughout Wheeler. It's important to keep them in that resilient zone to help them regulate. Otherwise, the hyper-arouse or hypo-arouse, and you won't get much education and therapy done when they're not in that resilient zone. The main therapeutic techniques that you're going to be using in this type of therapy include empathetic listening. It's a lot of and tell me more. Can you expand on that? Role modeling, keeping yourself stable, education on those stages of development, and questioning, clarification, reframing, and help them interpret what they've been through. And just understanding that memories are held in networks of neurons, and through therapy, we can help connect those neurons to really understand what's going on. And so ways to help them when they're deregulated, shift the focus away with breathing exercises. So when you see somebody that's dysregulated in your appointment, you can shift that away to breathing exercises. Use supportive communication techniques. Focus only on one aspect of the experience instead of the overwhelming nature of the bigger picture. Orient person to the present, so ground them. Normalize their reaction, saying that's an expected reaction. There is an exercise called safe place or container, and that Wheeler has descriptions on how to do those exercises, and explain that they're going to feel activated before and after what's going on, and convey that things will get better and you're there to help them. And definitely, if dysregulated, allow for personal space and don't touch the person. In terms of ego problems, you may see patients that are too loose and they'll act out, project fears, externalize conflicts, need a therapist who manages their behaviors. Or patients who are too strict, who internalize, who are out of touch with their feelings and need a therapist who helps them become more aware of their feelings. And then you have the highly resistant patients that respond best to interventions, while those with less restrictive respond best to direct interventions. So when we talk about ego, what does good ego look like? So a person who has a sense of well-being and self-respect and able to work and love, according to Freud. So somebody who just feels content and who's able to respect themselves and to able to do their job and able to have relationships. That would be considered for Freud to have good functioning ego. So ego functioning in the psychodynamic model organizes and integrates experience, protects with ego defenses, regulates feelings, learns from experiences, and then is a reality tester and screens perceptions. So looking at that, the next slide will look at kind of the strengths to help them do these ego functionings. So ego strength is the capacity for effective personal functioning, and all of these is kind of what you want to get the patient to learn in the therapy is about their self-concept, their self-control, self-soothing, intimacy, affect tolerance and regulation, realistic and consistent life goals. And then we talk about some levels of defenses that you will see. And you can pause this and kind of read through it. And the next slide will go over some of the defenses. So just being aware of what these look like and what they can produce in terms of defenses. Denial is a defense, not acknowledging there is a problem. Repression, suppressing a memory until it disappears into the subconscious. Projecting, putting your own belief or behavior onto someone else. So an example of that would be talking about how stupid a video game system is with someone else, believing that they must feel the same way even though they have never said so. So you're projecting your idea onto them. Regression, acting in a way that is not typical for your age. And you'll see this if you treat kids, you'll see this quite a bit. And this will happen when there's a new family member, something dramatic that might happen within the family, something traumatic that might happen in the family, where the kid will regress and start talking baby talk. I've experienced that with 12, 13-year-olds. All of a sudden they're talking baby talk to their parents and the parents don't understand. And I said they've regressed. They've had something happen and now they're regressing to cope. And then displacement, showing emotion towards someone or something completely unrelated to that which caused the emotion. And so this happens quite a bit, kind of blaming somebody else for what happened. And then rationalization, making up explanations for something that has happened. And then that example, a rapist thinking that since the girl he is raping looked at him seductively one time, it must be okay to rape her. He's rationalizing that it was okay for what he did. So chapter 3 discuss kind of like assessing the ego function. So really understanding the patient's impulse control, their relationships, their perceptions of realities, their defenses that they use, insight, transference, their symptoms, and psychosexual development. And within the psychodynamic concept, you want to build that therapeutic alliance, as we've discussed in other chapters. Psychodynamic formulation that we talked about. They use dream interpretation. And then transference and countertransference you have to be aware of within the psychodynamic relationship. And then, as we talked about in other chapters, the resistance. Looking at this, we have transference feelings, and those are the feelings that the patient projects onto the provider. And so they may feel criticized, fear of abandonment, will do anything to be loved, feels you are judging, and feeling humiliated, feels urged to defeat you. Those are kind of some transference feelings. If you're seeing these negative feelings, it's important to address them. But if there's, positive ones, you don't have to do anything unless it's more breaking boundaries, then you would definitely address it. And then we've talked about resistance before. The patient may not talk about their childhood. They're late, they cancel, they don't show up, they flirt, make you feel like you're pulling teeth, idolizing or devaluating, doesn't change, doesn't talk, has rigid posture, talks in cliches, is always cheerful or secretive. So that's resistance. And we've talked in other chapters how to work with resistance. Goals of therapy is symptom relief. You just want them to feel good. Restoration to prior level of functioning. They may be in acute distress, so you want them to be prior to that acute distress. Or maybe their prior level of functioning really wasn't functioning, so you don't even want to go to that level of functioning. And then the increased awareness of the role of early childhood experiences and traits and why they behave the way they behave. Understand link between now and then, and identify steps to change. So really helping them in terms of what is their treatment plan, what steps can we treat them with to help them change. And within the psychodynamic therapy, it's important to understand how it's the role of the unconscious that we're evaluating with psychodynamic therapy. And the client produces the consequences he or she avoids. And irony, free association, context, and change is a loss. So really understanding that and helping the patients work through that. So in terms of this, this might be how a patient presents and kind of the cycle within those dynamics that you see within a patient, and kind of understanding and stopping them. Like, I see you're angry, but you might see the anger go to anxiety, passivity, frustration, or ignored. And then you might see this in patients with like borderline personality disorder. That sense of abandonment makes depression, makes anxiety, makes them act out. And it's kind of cycling through that within that psychodynamic ability to see that within the patient presentation. And then when talking about, say, like narcissistic personality, you know, they have a low self-esteem, they have anxiety, depression, they're very shallow, you know, they tend to make things up, and then have bragging and exaggeration to help with that low self-esteem. So it's kind of this cycle. So when working with people with narcissistic personality disorder, really understanding that low self-esteem, and they can be difficult to work with. And so really helping them move through that low self-esteem may be helpful. When thinking about general principles, we have to think about different things we can do with the therapy. The important part is establishing a therapeutic alliance, and also remembering ways to deal with initial resistance. And we've talked about some of those ways. The importance is gathering historical material and other data. What is their most important problem? Why now? What has been done so far? What does the client think that caused the problem? And what does the client want to take away from therapy? And they may have a lot of things that is going on, and a lot of people wait too long. They just have this buildup of things. So select the symptom most amenable for treatment, and then define the precipitating event, and then present a working hypothesis to the client, and make a tentative diagnosis, and enlist the client as an active participant. And then again, this is all very specific with the patient, you know, making a verbal contract, using the most effective techniques to help with the client, study their responses and defenses, and be sensitive to how the past is influencing the present. And that's very psychodynamic, how the past is influencing the current. And then also examine any of your counter transference onto the patient. You know, you're finding yourself being irritated, annoyed, late for appointments, not finishing their note, or, you know, breaking boundaries in terms of letting them run over in the appointment, letting them run up a bill, things like that. Look for resistance within the therapeutic relationship. A lot of therapy gives homework for them to think about. Stress the need for continuing to work on it. Even if you end the relationship, they need to still work on it. And when you arrange for the end of the relationship, you know, just offer how that looks for them and if they can come back. And again, this is, you know, if you're primarily doing therapy, and most of us will be doing medication management. So really what to take out of this is really to understand those stages that Erickson has, that Freud has, kind of understanding when patients present with certain symptomology. Is it really a medication thing? Is it a therapy thing? Do you really need to refer them to therapy instead of giving them Lexapro? Because medication can only do so much. If they're stuck in a stage, Lexapro is not going to do anything for them. It may just blank them. And you'll get that, you know, patients will be like, well, I just feel numb. Yeah, because you really didn't need the medication. You know, now we're just numbing the feeling that you really need therapy to understand. So definitely understand those stages of development, what they look like in patient presentation, and kind of those modalities, and understanding the id, ego, and superego and what those look like and how you can adapt those within your patient presentation assessment.